Well, thank you all for joining us today. My name is Emily Kile, and I'm an attorney at Mushkatel, Gobbato, and Kile. We have offices in Scottsdale as well as in Sun City, and we practice in the area of estate planning, guardianship, and conservatorship, probate and trust administration, along with all-tex and special needs planning. And we're always here to be helpful to you, so if you have questions, please reach out to us at the end. And I'm totally thrilled to have Lori with us today. She is a licensed clinical social worker and the Family and Community Services Director at Banner Alzheimer's Institute and Banner Sun Health Research Institute. She's spent more than 20 years specializing in leadership and clinical positions, serving the needs of patients and families coping with emotional, cognitive, and behavioral problems. Ms. Nisson serves as adjunct faculty member at Arizona State University Edson College of Nursing and Health Innovation, and serves on the Arizona Dementia Caregiver Alliance, as well as the End of Life Care Partnership. Ms. Nisson was awarded a Practice Change Leadership in Aging and Health Fellowship, and she is a wonderful human being and a very good friend. So Lori, thank you for spending some time with us today to help us sort of understand some of the complexities that go on with behaviors and folks who are experiencing some cognitive decline. So thank you so much. And for our participants, if you have questions, if you want to type them in the chat or the Q&A, I'll keep my eyes on that. And if we have time at the end, we'll go ahead and answer questions, or we'll do so along the way. Thank you.
Excellent. Well, thank you, Emily, for that kind of introduction, and glad to be with you all today. We're going to talk a little bit about communication and behavioral change that happens with Alzheimer's and other forms of dementia. And I'm hoping that we're going to really cover some of the common communication and behavior changes that you might see. Talk a little bit about what might trigger or cause a behavior that you might see in somebody living with dementia. And then talk about some opportunities for strategy. What are some skills that you can learn to be better prepared? And then, as Emily said, I'm a licensed clinical social worker, so my lens is really non-pharmacological. So I'm going to talk with you a little bit about things you can do to modify your communication and strategies to manage behavioral change. But there are times when you really need to rely on your medical provider. And so we'll talk about, where we draw that line. So I think to back up, really, when we talk about dementia, and I know that even professionals kind of get this wrong. So I think I just want to share that really dementia is an umbrella term. It really describes the change in memory, thinking, language, behavior, can cause changes in communication, can cause changes in someone's ability to have good insight, awareness, and even judgment. But it's not a diagnosis. It's really a category. And so underneath dementia are different types. So you hear Alzheimer's disease being used interchangeably, but Alzheimer's is one type or one form of dementia. And so we have lots of different types, including Lewy body dementia, which is the second most common type. You may hear about frontotemporal dementia or a vascular dementia. But any of the dementias really affect people's ability to really manage things day to day, whether it's in their environment, whether it's in their job, if they're still working, whether it's in their hobbies or leisure activities. And it also affects communication and behavior, how people behave day to day and moment to moment and in different situations. Behavioral changes, though, and communication changes are really part of the disease process. And they're not typically volitional. So people will say things like, well, you don't know my mother-in-law. She's always been really difficult. And maybe she is or was, but now some of the changes that you're seeing are typically because of loss of memory and thinking abilities. And so it really requires care partners to be like detectives, to really anticipate needs. So that being said, even if this person was maybe difficult in your life, try to remember now that this is really the disease. They're not trying to cause problems. It's likely related to the disease. So we try our best to keep that in mind, use a little bit of empathy. So think about, if I were someone who was living with memory loss, how would I want to be treated? And then a lot of deep breathing, right? Because these moments can be very difficult. So I think about behavior as a purpose. It's often a signal of an unmet need. So, behaviors are often when language fails, someone is acting out what they want, need, or don't want. And so our goal is to really think about the behavior and try to figure out what might be causing it, what can we do to prevent it, or what can we do to address it differently to really de-escalate or have it decline or extinguish it. And just really kind of think about how our part of the reaction makes the behavior worse or less worse. So we can strive to have better outcomes. Because behaviors are difficult for people who are living with dementia, but even more difficult for care partners. But they're a normal part of the disease. So I think about Alzheimer's and other forms of dementia in stages. And if you've read about the stages, you might find, 3 stages or 8 stages, 12 stages. I think you can understand it pretty easily in 3 stages: early, moderate or middle stage, or advanced stage. The middle stage of the disease typically lasts the longest, and that's where we see most of the behavioral changes. So we talk about Alzheimer's disease, we usually see that in the middle stage or moderate stage of dementia, as the person is not as able to communicate. They're having more trouble kind of discerning and managing stress around them. But in other types of dementia, like Lewy body dementia, which I think of as like a hybrid between Alzheimer's disease and Parkinson's disease, you have memory and thinking changes. You also have movement changes, and we often see more psychosis or hallucinations. And then in frontotemporal dementia, where the behavioral change can happen much earlier even than the memory and thinking. We also see a lot of emotional changes that happen, particularly in the early stage of the disease. I've noticed in my practice that when people have greater insight or awareness into their disease, they often have more emotional symptoms because they might be thinking about what's coming or the losses that occur as a result of losing abilities. So it can be in the form of loss or frustration or even depression or anxiety. And we know that when we think about behavior changes, and we'll talk specifically about what those are, they tend to worsen as the day progresses. And so we hear about that kind of pop psych term, sundowning. That means that, as the day progresses, somebody living with dementia gets worse. And that's often because things that come easy to us are much more difficult for somebody with dementia who's trying a lot harder. So as the day progresses, they get more and more tired. And from your own experience that when you're fatigued, you're more irritable, right? And you're more susceptible to lash out or feel frustrated or angry. So I think the behavioral changes follow. The other thing that I think is interesting and difficult about this disease is as memory fades, so does function. So early in the disease, when someone's diagnosed, they might be in their 60s or 70s, and they might be functioning at a very high level. Maybe they're an athlete or someone who's taking good care of themselves and they walk quite well. But as the disease progresses into early to moderate, we see that memory and thinking declined, behaviors and emotions change, but also their functionality changes as the brain isn't communicating as well with other parts of the body. So, someone starts out ambulating quite well, and as the disease progresses, might need a walker, might need a wheelchair. They might be able to bathe and dress independently in the early phase, and in the moderate stage are starting to really need help with dressing and bathing and in the advanced stage need, really full care. So I think what's difficult about this disease is just that once you as a care partner get the hang of things, everything changes. There's a loss in function or communication or behavior, which makes it really exponentially more difficult for family caregivers. And we know that family caregivers have exponentially higher rates of caregiver stress and burden than caregivers of other disease states like cancer, for example. And I think it's really because, the care is multimodal. You're starting out as a caregiver and a care partner, and first you're just kind of supervising things and prompting the person. And before you know it, you're taking over their responsibilities, you're managing your own, you're doing hands-on care, you're managing difficult behaviors. So that's a lot. So I think when it comes specifically to managing behaviors and communication, it requires a lot of creativity, flexibility. We have to shift or change our thinking. We've communicated with this person. If there are, if we're an adult child, we're communicating with our parents, since we were born. So we have these patterns of communication. Same thing if it's a partner or spouse, you might be together 10, 20, 30, 40, 50 years, and now your normal communication patterns aren't working well because that person isn't capable of communicating in the same way. They don't have the same kind of rational thinking. And so we're asking a lot of you. You really have to shift so much of the way you communicate and manage day to day. So I think it's important to understand that someone living with dementia has a really hard time managing their emotions. Things that used to come very easily to them are becoming more difficult. So activities of daily living like dressing or bathing or brushing teeth, navigating an environment. And we see this a lot as many of us here live in Arizona, and some of our aging adults don't live here the whole year. So they are winter visitors and maybe go back to the Midwest, for example. And we notice that as the person's disease progresses, they're having a hard time adapting to two environments. It's very confusing for them. Communicating is becoming more difficult, tracking conversations, being able to express needs is difficult. And any change becomes difficult. So we notice that sometimes when, the daily structure is changed, that's when we see an increase in confusion, increase in behaviors, increase in difficulty in communication. Sometimes that's travel. Maybe that's when family members are coming into town and staying with you during holiday seasons, and you notice that your person is more upset or stressed when the daily routine is impaired, or there are people in the house that aren't normally there. And just day to day, making sense of everyday activities and sense of the world becomes much more difficult. So I think really it's important to think about behaviors as actions that are meant to communicate. Could be needs, could be expression of feelings, or what that person's trying to tell you. Often behaviors are just a sign that we need to put our detective hat on and figure out what the person's trying to communicate. So late in the day, if there's a lot of noise in the house, or you're at Costco or Walmart or someplace that's really overstimulating, that person's going to tell you through their irritability, or that they keep asking you to go home, that it's too much for them. Maybe they can't say, hey, this place is crazy right now, or there's too many people, or there's too much noise, or somebody keeps, narrowly missing me with their cart. Instead, they're going to act agitated or irritable, or we've even seen cases where someone strikes out because they can't communicate that the environment is just overstimulating for them. So I think we have to just really pay attention. I've seen people who, are in a public place and they're just kind of pulling it at their pants, and you're wondering what that's about. Well, maybe it's that they need to toilet and they can't tell you that, and they don't know where the bathroom is because they're in a different place or have forgotten where it was. So I think, and I'd be interested if you feel like putting it in the chat, if there are specific behaviors that you found to be difficult or ones that aren't on the screen that you've noticed that in your person or the person living with dementia, but often it's in agitation or restlessness. Sometimes it's delusions or false fixed beliefs, or maybe even paranoid thoughts. Maybe the person is just less inhibited, and that seems embarrassing to you. Or maybe they are doing things like wandering or irritable, verbally, yelling or calling out or even acting out or even striking out if they're in a situation that feels really uncomfortable to them. But you also see things like collecting things, rummaging, losing items because they're having trouble remembering and tracking those things. Sometimes it's agitation or even anxiousness. We see a lot of separation anxiety, for example, when if you're the primary care partner and you leave, the person might be really anxious because you've become their brain, you've become their structure. They rely on you, and when you're not there, they feel a really high level of anxiety. So before you intervene, ask yourself, is this really a problem, and whose problem is it? So I've had caregivers who say, well, I'm just embarrassed because my person, I take them out and they've been wearing the same shirt, and that embarrasses me. It's my job to make sure they're clean and neat and have, a nice outfit on. Is that really a big deal? If they're really attached to a navy polo shirt, can we buy a few of them and just swap them out when they're not paying attention or when they're in their bedclothes? Whose problem is it? Is it yours or theirs? And do you really need to intervene? So, as we said, behaviors really have a cause. But if that person has a behavior, ask yourself, why did it happen? What changed? And what is he, she, they trying to tell me? So in the Costco scenario, think about it. It might be fine for you to be in Costco or Walmart or Target when it's a busy time of day, but think about for somebody with dementia who gets easily stimulated, is that the best time? What is that person trying to tell me? I was working with a family last year, and the gentleman who had dementia was in the moderate or middle stage, and his wife was caring for him and had taken him out to dinner with a few of their adult children. They went to dinner kind of late, which is normal, right? 6, 7 o'clock at night. But I think the situation was very overstimulating for him. And they were leaving the restaurant after a very noisy meal. And his son-in-law said something that he didn't like, and he hit him on the back of the head. And the family was very distressed about this. They were having a hard time the son-in-law was having a hard time not personalizing this. And it led to actually a lot of family conflict. So we were having a family session and we were kind of talking about this and talking about, well, why did this happen? What changed? What do you think Joe was trying to tell us? I wasn't there, but I think that it was too many people around, too late in the day. He was too exhausted. And it probably really didn't have anything to do with the fact that, whether he liked or disliked his son-in-law. It was really something that he shouldn't personalize, but that to prevent this from happening again, we might want to have a family dinner at home and bring in food so there's not so much noise and it's a family that all the people are recognizable and familiar to him, and maybe a location that's more familiar to him. Or if we really want to go to a restaurant, maybe we need to go at like 4 o'clock when there's not that many people there. Maybe that wouldn't be so overstimulating. And then just really counseling the family about the fact that these behaviors are not volitional. They're often not because they like or dislike the person, but more about just expressing emotion or frustration or anger, and the person's disinhibited, right? Where Emily can take a look at me and think, oh, I really wish you wouldn't wear that burnt orange tank top, that's really inappropriate. She's going to keep that to herself. But if it's somebody with dementia, they might lash out like, that's ugly, or you look fat, or all those things, because there's no filter. The same thing with behavior, where I might think, oh, I'm really frustrated, I kind of want to punch that person. I'm just going to keep that inside, take a deep breath, and let it go. But if I don't have a filter, my frontal lobe's impaired, I'm just going to act on my feelings. So I had to really explain that to the family. And it really took a long time for them to kind of understand that this behavior was something that was happening, probably because of a multitude of factors, but it really wasn't personal. And so we had to really eliminate some of those triggers to help Joe better manage the environment and to reduce his stress. So what are triggers to behaviors? So I told you about a few of them in that particular example, but I think about them in different ways. So these are environmental triggers that I think, and evidence base shows that common environmental triggers are just misperception. So if someone's in an environment that's not familiar to them, that can really cause them stress. Any change in routine. So if my spouse or partner is my primary caregiver, and that person has to be away for a few days, and there's a stand-in caregiver, that's going to cause stress for me. Doesn't mean the person shouldn't take respite. It just means we should expect that, and figure out ways to try to create, a more soothing space or environment. Providing care. So just the act of actually providing hands-on care puts us in a very intrusive position. So even though you've hired an outside caregiver that your person has known for a few weeks, and they say, hey, Joe, I'm going to bring you into the shower now. We're going to clean up and get ready for a doctor's appointment or to go out for lunch. Once we get there, if Joe's in the middle stage of dementia, he's already forgotten who that caregiver is and what we're doing there, and might think, oh, this is a nice, attractive young woman. We're in the shower together, and she's kind of cute. So might grab out at her. And then that causes all kinds of problems, right? Because those hyper affectionate or hypersexual kinds of behaviors don't go well in our society. And all of a sudden there's a lot of problems. So just being in an intrusive position with someone can create problems. The other thing is that, I took a shower in the bathroom with my door closed today, but all of a sudden there's someone in there with me, and I know how to shower. I don't want you in there with me, Emily. I can do this just fine. So now I'm really pissed off because you're in my space, right? I have privacy, and I like to do those things at home. So that can trigger behaviors. And then the environment, too much or too little stimulation. So we see this in a nursing home setting all the time, where there's a loud loudspeaker, or the person's sitting in a wheelchair near the nurse's station. They haven't had any activity all day. By 3 o'clock, I don't know about you, but if I haven't moved my body, I'm feeling agitated and restless, right? I'm hearing lots of noises that frustrate me. And so I'm going to get agitated and upset. I might even strike out if you just simply came over and said hello to me. Any change in the environment can cause problems. And this fine balance of not enough activity or boredom or too much activity can really set somebody off. So it's a fine balance. The other thing that I think can really trigger people are physical or physiological triggers. So just the fact that I can't sort through things as easily because my brain is not working well can cause me to want to act out or feel frustrated. Even just not being able to get the words out, or I'm telling you something, but you don't understand me, and I feel like I'm saying it very clearly, even though it doesn't sound clear to you, can be frustrating. Any pain or illness. can cause a problem for the person. They might not be able to tell you, hey, my left knee has been bothering me. I need to see the primary care doctor or my orthopedic doctor. But instead, they're grimacing, or maybe they're really stiff when you first get up in the morning and they're grimacing or crying or even swearing, right? Because they can't tell you that they are in pain, but they are in pain. So that often gets expressed emotionally or through actions. Any kind of infection can cause a delirium. So confusion on top of confusion. So any of us could have delirium. So today, in the afternoon, I don't know, I think it's going to be 105 degrees out. If I decided to go hiking and I didn't bring enough water and I'm not an experienced hiker, I'd get dehydrated and I could become delirious, right? I'm dehydrated. I'm seeing an oasis in the distance. I'm acting strange. That's delirium. Older people are at higher risk for delirium. Older people with dementia have a higher risk for delirium, and they're much more sensitive to it. So a urinary tract infection can cause somebody who's confused at this level to really tank. They can start hearing or seeing things that are there, acting like they're seeing things in the air, acting out behaviorally all of a sudden. So this sudden change in mental status and behavioral change can be a result of delirium. And delirium can be triggered from any kind of infection, COVID, pneumonia, cold, a urinary tract infection, even constipation can trigger delirium. Also, side effects of any new medication. If the person is going to have anesthesia because they're going to have some kind of surgical procedure, that can really trigger delirium, and that causes lots of behavioral disturbance. And then any unmet need. So, you think you've been putting water next to your person, you think they're drinking it, but they're not. They don't remember to drink it, or you're not hydrating them enough, or they refuse to drink water, or they're hungry and they can't tell you, or they're extremely fatigued. This is a disease that can impact the circadian rhythm. So, they're not sleeping well at night, or they've got their days and nights transposed. Any toileting needs, or just any general discomfort, satisfaction, or distress physically causes behaviors, right? So it's difficult. It's a difficult thing to navigate. But I would say if you notice anything under that pain or illness, or just suspect it, you should talk to the doctor about it, because it may be that we need to prescribe something for pain. It may be that we need to do a urinary tract analysis, a UA, or it might be that if it's a new medication, you need to share that you're noticing some side effects, because obviously the person can't tell the physician, and there may be something that could be done about it. So I think, behavior or emotional changes happen at any stage. As mentioned, we see the greatest number of behavioral changes in the moderate stage of Alzheimer's disease. And even in early stage, we can see that the person's, more irritable, maybe having difficulty remembering things, having problems with word finding. Maybe that's when, you've seen your elder law attorney, and Emily is saying, it'd be a really good idea to, make sure that, we have all the advanced directives in place, like your healthcare and mental health care and financial. And, it might be a good idea as a partner to help kind of supervise bills and things like that. And that's where sometimes the person can start getting paranoid, because they're in their mind, they're the same as they have been all along. And now you're in my bank book. And what are you doing in my bank book? And why are you in my finances? That can trigger some paranoia, even though maybe we talked about it yesterday. I'm just trying to help you. I don't want you to miss a mortgage payment. I'm just trying to make sure the bills are paid on time. But to me, I don't have good insight. So I'm thinking, I've been paying my bills since I was 15 years old and, went out on my own. And what are you doing butting in? So that sometimes can trigger things like paranoia. In the moderate stage, it's pretty obvious that the person can't manage on their own. And so if we don't supervise them, they might be doing things like wandering. In the afternoon, that's when they're going to get restless. They might have problems with eating or sleeping, or those kind of hyper affectionate or hypersexual behaviors that we see, especially with things like hands-on care or maybe even in the bedroom. In the late stage, as people advance in their disease, we actually maybe don't see as many behaviors because they're not quite as expressive. They're more muted. They're more internalized. They're not connecting with the outside world as much. But we certainly can see problems with things like care, falls, physical restlessness, disruptive sleep patterns, having trouble eating and swallowing, especially people who can't walk anymore. They might be calling out or feel very restless if they're in a wheelchair without somebody helping them walk, or at least repositioning them so that they're more comfortable. So what can we do to prevent problems? I mean, prevention is always the key, right? Well, rest periods, I think, can be really helpful. We certainly don't want the person napping for a couple of hours in the morning or afternoon because we don't want to do anything to disrupt the nighttime sleep, especially if you are the full-time caregiver. Because if that person isn't sleeping at night, I know you're not, and then I'm worried about burnout. And that's a recipe for disaster. We want to reduce noise and distractions. So before I joined Banner, I did a lot of dementia and behavioral consultations, and I would often do those in home or in an assisted living center or a nursing center. And I would notice that there was often a loud television playing, right? And so as people age, they have problems with memory and thinking. Not everybody, but a lot of people. And then lots of us have sensory deprivation. So we're not seeing as well, we're not hearing as well. So that television would often be, on level 60. And a loud television is very stressful for somebody with dementia, especially when they're progressing in the illness. And it's hard for them to discern what the pictures are, or they get caught up in the story that's about wartime and they get really agitated. Maybe they're remembering their time that they served in the military. So reducing noise and distraction, particularly as the day goes on, is going to be really helpful. Even if you have to make excuses like, I'm really tired of the news. I personally don't think a lot of news is healthy for people with dementia or any of us, frankly. So even if you have to say, I've had too much news, let's listen to some music for a while. That would be a good intervention in the afternoon. Turning some lights down low, turning off all devices could be helpful. And then trying to find meaningful activities, like maybe the person can no longer golf 18 holes, but if golf was a passion, maybe they can golf 9. If they can't golf 9 holes, can they putt? If they can't putt, can we have lunch in the clubhouse or walk the greens or take, walks? Are there things we can do to keep that person engaged in a meaningful activity? Because I think our natural reaction is to say, oh, well, they can't golf 18 holes because they can't concentrate, or it's too long, so they can't golf anymore. But can we shape what they're doing or find even just household activities for them to help us with, whether it's setting the table, unloading the dishwasher, folding clothes or towels? Because everyone needs to have a sense of purpose, and meaningful activities can also reduce agitation. So trying to step into that person's world rather than trying to pull them into yours. And then redefine your expectations. So a wise caregiver in one of our support groups once told me, whenever my partner frustrates me, my work frustrates me, my children frustrate me, or my aging parents, one had Alzheimer's, one had Parkinson's disease, I have to redefine my expectations and not set them and me up for failure. So how do we approach managing behaviors and communication. We try to find and address the cause. Is the person going to the bathroom more often? Maybe they have a urinary issue. We need to have the doctor run, an urinalysis. Are they coughing and sneezing? Do they maybe have COVID or pneumonia or cold that needs to be treated? Are they in pain, or do we suspect they're in pain? Do they maybe have arthritis? And if so, is there medication that's non-habit forming that could help, reduce pain? Because we're all irritable when we're in pain. Keep our nonverbals calm. So that means that a lot of our communication is done non-verbally. So if you are frustrated with your person all the time, they are going to mirror that emotion. So that's probably a sign that you need more breaks, or that you need to step outside to take some deep breaths. Keep our communication simple and slow. So I'm from Chicago, so I walk fast, I talk fast. That's in my blood. But when I'm with somebody who is living with dementia, I have to slow down. I have to talk more simply. I have to watch my emotions so I'm not frustrated. I smile a lot because I know they're going to mirror that. And if they do get upset, we have to address the emotion. We have to say, I'm sorry you seem upset. And if you're upset, I'm going to do everything in my power to fix whatever the problem is. And if I don't know what it is, I might just reassure you. I'm going to calm the environment down. So if I notice that having the grandkids over is a lot, I'm going to have to, keep those visits short, or maybe just do them in the morning during my person's best time. Or maybe it's just too much for them. And when I have caregiver or they're going to an adult day program, that's when I'm going to hang out with the grandchildren who are young and maybe a little boisterous. And removing triggers if there are certain things that upset that person, like they can't drive anymore. I'm not going to be leaving keys out because that's going to trigger an argument or upset. And then, we have a saying at Banner Alzheimer's Institute, you're never going to win an argument with somebody with dementia. So even if what they're saying is completely wrong, just using an agree, apologize, or distract approach is going to go a lot better than arguing with them. So a gentleman I worked with a few years ago was taking care of his longtime partner, and they lived in Sun City. And his partner all of a sudden decided he wanted to go back to Iowa. And originally he started saying to him, well, why would we go back to Iowa? We don't even know anybody there anymore. The people we knew were either have died or moved somewhere else. So that's such a silly plan. Well, his partner, who had dementia, got very upset, and he would get up, walk out of the room, go in the bedroom, and slam the door. Not a very good outcome, right? So I said, well, could we kind of try to replay this scenario and see if we could use these principles of agreeing, apologize, or distract? And he's like, yeah, Lori, whatever you say, let's try it. So instead, when your partner says, hey, I really want to go back to Iowa, it might be a sign that maybe he's uncomfortable. So should we look into what's going on? We might say, hey, you're right. We had some beautiful times in Iowa. It was a lovely place. Do you remember when we used to walk our dog around the pond? We had some really good times there. I think it would be nice to take a trip back there and see some old friends. I'm sorry, it's going to take me a little while to look into that trip and to organize it. But I think that'd be a good idea. And thanks for the suggestion. I'll look into it. In the meantime, it's about 20 minutes to 1, and we said we were going to watch that Western at 1 o'clock. So let's go pop some popcorn, get settled in the den, and get everything ready. So just a simple example about, agreeing, apologizing, and distracting. So even if the person is adamant, I want to go back to Iowa, I'm really sorry. I'm not going to be able to make that happen today, but I'll work on it. In the meantime, let's go for a walk. The weather's cooling off. We could both use some exercise. I think that would be a great thing for us to do and try to distract the person. The best and worst of us, even the very best caregivers have moments where we stick our foot in our mouth or we do something because we're just frustrated or overtired. Caregiving is a very intense job. It can be very rewarding, but we all do things that don't work out well. So these are the things we want to try to avoid. So correcting the person. We lived in Iowa last year, and it was wonderful that we haven't lived there in 10 years. Is that really important to correct the person? Step into their reality, go with it. Trying to reason with them. So I had a session with a caregiver this morning, and her husband has finally adjusted to adult day programming. He only goes half days, but now her mother has moved in with them. So her caregiving has now doubled, exponentially increased. So I was saying to her, now that Joe is settled into this adult club and seems to be fine and isn't having separation anxiety, let's do a full day. She's like, well, I'll talk to him about it. I'm like, no, I don't think we need to talk to him about it. He's in the moderate stage of dementia. When I talked with him earlier, he wasn't able to answer many of my questions. He didn't remember. He didn't even remember that his mother-in-law had moved in with them about a month ago. So I don't think that having a conversation about extending the time at the adult club is useful. We are just going to go for it. We're going to talk to the staff and just make sure that he's still adjusting well, and just ask if that's a possibility and then go for it. That's totally counterintuitive to how they've lived the last 50 years of their marriage, where they would talk about, confer, and move forward on a plan, right? But not when the person can't reason, not when they can't have a conversation about it, not when we're going to ask a question that we're going to get a no. We try to avoid that. So we want to avoid reasoning. We want to avoid arguing. We want to avoid reorienting. So we don't want to constantly, tell the person time of day. It's not important. Whatever day they think it is, that works out for me. We don't want to tell the truth, the whole truth, and nothing but the truth at all times. I know a lot of caregivers get angry with me about this, but telling the truth is overrated with dementia. Not useful, not helpful. It just agitates the person. So, if I'm going to employ care and I know that my person doesn't want a caregiver, I frankly don't want a caregiver, right? I'm an adult. I'm going to call that person an assistant. I'm going to tell Emily that I'm implementing this assistant to help me, and they're not going to bother her at all. And then I'm going to say, I got to run a few errands, so don't mind this assistant. This person's not going to get in your way. They're going to do some light housekeeping, and I'll be back in a few hours. We want to avoid over-explaining. Women, we are the worst at this. We feel like we have to explain everything to the 10th degree. Not useful. I've got an assistant. We're going to get moving. We don't have to explain everything in lots of details. The person is not going to be able to respond. They're not going to be able to remember. It's not useful. Exposing our own frustration or anger. And I know this is a tough one because caregiving can be tough, right? The care load keeps climbing. But trying to avoid frustration or anger in front of that person is going to be helpful. Having unrealistic expectations or demands. So if the person has always been able to dress themselves, but they can't anymore, telling them to go in the other room and get dressed and ready and come out is not going to work out. We're just going to walk in there and they're still going to be in their pajamas, and then we're going to get frustrated. So we have to have realistic expectations. We might have to set out their clothes for them. We might give them 2 choices if they want to pick something out, because a whole closet is going to totally overwhelm them. We might have to actually help them with putting on the shirt or top, or we might even have to change the way we shop for clothes. We might want, a shirt that zippers in front to make it easy, or a button down that might be easier. We might want Velcro gym shoes, even though maybe they're not as stylish as the ones that the person used to wear before. We have to be practical and have realistic expectations, do things to make things easier for that person and for us. We want to avoid finger pointing or scolding the person when they do something wrong. It's not volitional. They're not trying to make us upset. We need to just take a deep breath, let it out slowly, and let it go as best we can. Or go into the bathroom and scream and yell. We want to avoid trying to teach the person something new. So if they already know how to use that flip phone, do not upgrade them to a different phone because they will not be able to learn new technology. If they used to be able to use the computer well, and now they keep screwing it up and getting us locked out, teaching them to use the computer is not going to be valuable. We just have to figure out a way to keep them out of the computer and find something else that's going to be more manageable for them. So what do we do when behaviors spike? How do we reduce them? We want to be proactive, provide those rest periods. So afternoon when the person's overwhelmed, and everyone has a different best time of the day, but for many people with dementia, that's going to be the morning when they're more fresh. Maybe they didn't sleep well, so maybe it's not morning and they need a rest period. Maybe you need a rest period. This is when we turn on some soft music and we get in the recliner and we both just sit and listen to some music or listen to a short story on an audiobook. Figure out ways to just have quiet time. We want to keep that person engaged with activities. And I think I gave some examples earlier about how to shape, golf, for example. I think we should definitely employ physical activity. And I'm going to show you that on the next slide. But I think physical activity is underrated. And I don't mean run, a marathon. I mean, just moving that person's body, even if they can walk with you to the mailbox and back, will reduce energy. I'm a perfect example of that. If I don't get 30 minutes of exercise, I'm not someone you want to be around. It's a good way to get rid of unwanted energy, right? It's kind of like that analogy of taking toddlers to the park to wear them out. Exercise or movement can be a good way to reduce energy or reduce agitation in human beings if we can do it at their pace. Maybe it's just chair stretches. We want to maintain as regular a routine as possible and just know that, we have to be flexible. Some days are going to be not so good days and we might talk less, we might do less. We have to expect that during a holiday season, things are going to be more agitated. We might want to modify even those activities. If we used to go over to our son's house for Christmas Day and we got there at noon and stayed till 8 o'clock at night, it's probably not going to work out too well. We should probably take our own car. We should probably ask to have the meal earlier and know that we're probably going to exit after 2-3 hours as the person may get restless. We're going to agree, apologize, and distract rather than argue with the person. We're going to do our best to modify our reactions, learn more about the disease, learn more about communications and behaviors, and do our best to increase our patience, to let things go, to recognize that not everything has to be perfect. So the caregiver I was talking to this morning, who now is taking care of her mom and her spouse who has dementia, was telling me that she hurt her back yesterday because she was cleaning out the pool. So I was saying, one of the best things you could offload as a caregiver, you can't do everything, is the pool cleaning. And she's saying to me, yeah, I know that, but we do have a pool cleaner. But, it was a windy day yesterday and there were lots of leaves in the pool. I realized that she wants her pool to look perfectly, and I totally get that. But we can't do everything. We have to accept less than perfect situations. So if the pool's a little messy and it means that you got time to put your feet up or you didn't hurt your back, you have to, weigh the risks with the benefits. So one of the first things, I try to get people to do to offload is, things that they can, if they can afford to, landscaping, pool service, housekeeping in their house, other things, as especially, if the person's living at home with them and they're caring for them full time, or there are other things they can outsource, and then we start talking about other things as the person moves from early to moderate, like in-home care or adult day programs, or should we be looking at assisted living? So we want to try to accept our person as best as they are in the moment. We're human beings and we have a tendency to live in the past and live in the future, right? We're either Emily's thinking about all the things she was supposed to do yesterday on her to-do list that she didn't get done. And she's also thinking about, oh, it's a holiday weekend, so I've got a plan for how I'm going to get everything done before I leave on Friday to go have a relaxing holiday weekend. And and as a caregiver, I'm thinking about, oh, I'm so sad about my person not being the same as they were years ago. I miss that person. I'm grieving that loss. I'm managing things okay, but now I'm worried about how am I going to manage as the disease progresses. That what happens is we lose out on today, which is our person's very best day, right? So sometimes we have to just do our best to plan for the future, let go of what we didn't do yesterday. It's okay. And accept our person as they are in the moment and do the best we can. So one of my colleagues is a DNP. She has a doctorate. She's a nurse practitioner, very bright person. She put together this slide and I stole it from her with permission. It's evidence-based research on studied interventions to reduce agitation and behaviors in somebody living with dementia. So there is some data around massage or therapeutic touch, especially if it's someone that you're close to and they're comfortable with you, massaging or putting your hand on their shoulder to help relax them. Playing their preferred music. So this couple I met with this morning, I asked him about his music. He couldn't tell me a lot, but he could tell me that he liked rock and roll. So playing rock and roll, classic rock. He likes Chicago, the Doobie Brothers. That's going to be something that he's going to relate to, connect to. Maybe he could even dance to it. That could be a form of exercise. Use of aromatherapy. There's data around lavender, which you can get mostly anywhere. Lemon balm or melissa leaf oil. You can use lavender oil. You could put a drop on someone's pillow to promote relaxation for sleep. You could get a diffuser. There are lots of ways to use aromatherapy to kind of calm the environment or stimulate it. Things like citrus could be used during the day when you're trying to activate. The same thing with music. If we're trying to relax in the afternoon, we could be playing classical music or chill music or spa music or whatever that person could relate to. If we're trying to exercise or activate in the morning, we might be playing rock and roll or something that really will stimulate us. Sounds of nature. There's a lot of data around things like birds chirping, ocean waves, or even white noise, which could be relaxing or therapeutic for any of us. Excuse me. Pleasant activities, things that person enjoys. Interactions with pets can be therapeutic. Even if it's not yours, maybe it's the neighbor's dog. Simple social interactions or connecting to do reminiscing activities like looking at photo albums of travels you've taken or a photo slideshow of the grandkids. That person's favorite foods can be helpful, and physical activities, as mentioned, to align with their abilities. So when all else has failed and you've tried everything, this is when we really want to think about partnering with our medical provider. That could be a primary care provider, and I say provider because it could be physician, it could be a nurse practitioner, it could be a physician assistant. If there's an abrupt change in behavior, mental status, or function, we talked earlier about how certain things can trigger a delirium. So a urinary tract infection, COVID, any of those things, if the person just had surgery or a new medication, if there's an abrupt change in their behavior, you should let the primary care provider know, because we've got to get at what the root of the delirium is caused by. Is it dehydration? Is it the new medication that's not working out well? Is it that, we really need to make sure that there's not some kind of infection? Because once we treat that, they'll go back to their baseline, or mostly back to their baseline. If you suspect any kind of pain or infection, or maybe it's a chronic condition. I mean, as we have aging adults, they have lots of comorbidities. So probably somebody with Alzheimer's disease maybe has, if they're in their 70s or 80s, they probably have arthritis. They might have hypertension. They might have diabetes. So all those things, if they're not stable, can make the memory worse. So we should be looking out for that and partnering with the primary care provider. If you suspect your person is really depressed, there may be an antidepressant that could help stabilize some of the emotion. If there are hallucinations, so they're hearing or seeing things that aren't there, delusions, believing something that's not true, or paranoia that is disruptive, that you can't redirect, they're so paranoid that they're not eating, that's a problem. If there's violence, if there's aggression, especially if it's directed towards you or other caregivers, or if just simply you've used all these strategies or many of these strategies and they're not working, that's really where you should be talking to the primary care provider or specialist if you see a geriatric psychiatrist or neurologist, or geriatrician, to say, hey, this is not going well. What are my options? This is what I'm seeing. I've logged some of the behaviors. This is what I can tell you. This is what I see it's happening. And I've tried to do everything I can, but it's bad and we need to intervene. And how can you help? So I'm going to stop now and just see if I don't know that we have any questions, but I'll let Emily be in charge of that and invite you to put a question in the chat. We have a couple minutes left. And I also just put a couple things. We have a great podcast that may be of use to you, Dementia Untangled. We have a newsletter you could sign up for. We have lots of classes, events, support groups. They're all free. So if you have an interest, those are opportunities to access them.
So thank you so much, Lori. No matter how many years I've been doing this, I always learn something and also get reinforced on ways to communicate with folks who are having challenges. I think for lots of families that we hear from at the beginning, they're feeling like their loved one isn't trying hard enough, that they're not paying attention, that they're trying to be difficult. And so being reminded that that might be a really early stage of that person's inability to kind of follow through on what you've requested. And so just like with a child, instead of giving 3 instructions, maybe the instruction is 1 and then making sure that's completed in the next. So always very, very helpful. So much appreciate your expertise and your time today, and the work that Banner does in the community and all of the free services and opportunities that folks have in order to try to make life better for themselves as well as for their loved ones. So thank you so much. Thank you to our participants, our attendees who are listening. If you have any questions, of course, you can reach out to us or to Banner, and we're here to be helpful. So I wish everybody the best, and we hope to see you all next week on our next webinar. So thank you.
Thank you.